Good evening, everybody, and welcome to the second part of our virtual seminar series, The Art and Science of Practical Management, Core Skills for Leadership and Management with Professor Joe Martin. My name is Dr. Matthew Clark, and I am a neuropathology trainee and the chair of the Trainee Advisory Committee for the Royal College of Pathologists, and I will be sharing tonight's session. A big welcome to all those people who have returned after our first session last week, and also a big welcome to all those who are new to the seminar series as well. For all of you, last week's presentation was recorded and will be on the website of the college later this week, so by Friday, if you'd like to have a look at it again, or if you unfortunately missed it last week. Just to remind you about the format of the session tonight, we will be having a presentation from Professor Martin for about 15 to 20 minutes, and then we will have a Q&A session at the end to finish off, and we should be finished around 7:30, 7:35. Just a bit of housekeeping. You'll note that all your microphones and videos have been switched off, and this is just to help with connectivity to ensure the efficient running of tonight. But we would love to hear from you if you've got any questions for Joe. You'll see at the bottom in the tab there is a Q&A function. If you've got a question that you'd like to ask Joe, please type your question in there. You can do it during the presentation or at the end, whatever you prefer, but we'd love to have your questions and your thoughts about what she talks to tonight. So without further ado, I will hand over to Joe, whose presentation tonight is Follow the Money, Commissioning and Financial Flows. Thank you, Joe.
Thank you very much, Matt. That's great. And thank you all for attending today. I'm going to start up with sharing some slides with you and talking through the money. So money makes the world go round, as they say. And in the health service, it is no different. So we're going to explore why you should know about the money, where it comes and goes to. And then when you're actually looking at making a business case, or when you're being asked to save money, what should you think about? This is really important stuff if you want to get stuff done and if you want to achieve stuff. It'll also help you understand sometimes why you get blocked. If you want to do something that's amazing and everyone goes no, then one of the reasons why they might say no is because of the money. So if you want to manage it, you need to know how it works. If you want to change it, and you need to know what levers you can use. So I've managed lots and lots of departments, and during my career in clinical management, I've never had a rise in budget. I've had to reduce my budget. I think virtually every department I've run, every division I've run, we've had to reduce the budget year on year. I think we're seeing some of the consequence of that more recently. But the other thing is, if you've got a rise in activity and you want to get more staff, or you want to put a change in, if you want to get some more analyzers, or you want to implement a new service, for example, a fine needle aspirate service for lumps and bumps, a one-stop clinic. How do you make that case, and how do you make that case in the context of the finance? So all health systems, many of you will be international, most health systems run on a combination of taxation to support public services for the most poor, and then individual contributions stroke private healthcare. In the National Health Service, I'm going to use that as the largest example. In the National Health Service, we run a national insurance system, NI, where you can look at if you look at your wage slip, you'll see a contribution to that, and that goes towards healthcare. It's not the only money that goes towards healthcare, but that is some of it. The NHS had in 2019 had a big budget of £131.3 billion, million pounds, say billion pounds. And that was divided into paying for about £6 billion worth of capital and £125 billion worth of revenue. One of the key things that you need to know is the difference between capital and revenue. Capital buys stuff. It buys stuff that stays with you. It's buildings, it's heavy duty machinery, it's CT scanners, it's analyzers, it's stuff that you buy and you don't buy again necessarily again next year. Revenue is stuff that you keep on buying, and that's people, that's consumables, it's electricity also, the payroll costs, things like that that are year on year. That's the equivalent of your bills, whereas your capital is the equivalent of your your PC or your tech or your sofa. Not too many sofas in the NHS. So that's the difference between capital and revenue. And we're going to come back to that, because this may all sound terribly tedious, but it's actually really relevant to the way you become an effective manager and leader. That revenue budget in the NHS, it goes towards paying different chunks. And the chunks are given out to pay for vaccinations, public health, training NHS staff, that's HEE, Health Education England, and regulatory costs. Then there's specialist commissioning, that £28 billion. That's separated off. It doesn't go through local commissioning groups, because it's thought that the specialist expertise for particular rare cancers, for particular specialist services, need national oversight rather than local oversight. But the vast majority of the money, 84.5 billion, goes to effectively local or regional commissioning. That's for both primary care and acute services. And that's this separation of commissioning and provider that was set in train in the NHS post the Lansley reforms. So it separated off who was buying the services and who was providing the services. Most of it's done through commissioning groups, either primary care networks, primary care, single CCGs. So that's the where the budget goes. But actually, how does it work in a department in practice? So I'm going to show you this diagram, which is actually about a GP practice, but it gives you some idea of, it's a bit more global, whilst it covers partner income, which you can see, which is not something that's relevant to most of us who work in acute care, but it may be some of you do work in primary care. So the income of a GP practice comes from a global sum payment, which is related to activity. That relates to the number of people they've got on the books. Then there's contracting services, so enhanced services, which might be school nurses, it might be providing diabetic screening, it might be other particular, if you like, ring fence services. Then you've got QOF, which is essentially quality payments. So it was decided that everyone should have their blood pressure recorded, and that became a goal with an attached payment. And that was, as we talked before, that was a goal-derived incentive. It was a motivator. It was a money-based motivator to get the recording of blood pressure measured more effectively, and it worked very well. It meant that the primary care recording of blood pressure throughout the NHS was near on 90% in many places. Training, primary care, organisation payments, medicines and items also all come in as income streams, and there are payments for IT and premises. Outgoings, again, consumables largely here. Interest and depreciation is on capital. So capital, any capital that you have, you sort of write it off in the books, you write it off over a number of years, and depending on your accountancy method, you can write it off over 5, 10, 20 years. So here at the Royal College of Pathologists, we've got a brand new shiny building, and that is essentially written off as a capital expenditure over a number of years, and GP practices and the health service are no different. So they essentially allocate a portion of that expenditure each year and write it off their asset, write it off their asset sheet. So they put it in a different box, if you like, on the accounting. But your income and your expenditure largely are supposed to balance. This in GPs, there is a partner income element to that. And then you've got your own expenses as an individual. So when you think about dividing up those particular payments, those particular income, it's the same in acute care, and it's the same for all of you. Let's talk my salary. So my salary is made up of two bits. I'm a clinical academic. Half of my salary is paid by the university and half is by the trust. But actually behind that, there's a whole mass of income which is related to paying that element of my salary. So on the university side, there's research income, research overheads, there's student fees, and there's contracted work. So it's essentially consultancy type work that university staff do that goes into the university budget, and that some small portion of it will filter down as part of my salary. And it's the same on the NHS trust side. So NHS trusts get their funding through that allocation system that we discussed earlier, through the commissioning. So they have central NHS England or funding, which comes in via the commissioning groups, the CCGs, which is partly related to activity. I've missed off here because it was getting a bit complicated, but there are additional payments for quality, similar to the quality outcomes framework that we saw for primary care. NHS trusts get Sequin money, which is quality improvement money, and they also get best practice tariffs, which are essentially payments for doing good things. So you get a financial incentive at a trust level to get more, and that results in you getting more money if you do what they want. Then there's the specialist commissioning money, the national level funding in blue at the bottom, and screening monies, which come in to pay for screening activity. The department may do private income. So there may be private income coming into, and in some trusts it's very considerable. So for example, Great Ormond Street, I think it's something like 42 million a year, maybe even more, comes in from private income into the trust. So some trusts have a lot more private income than others, and that's run through the trust rather than, we're not talking private income as in somebody to go and work in a private hospital. Actually, I don't do any private income for personal gain. Just a disclaimer on that one. Part of my salary also comes via Health Education England into the trust, which is contracted to provide undergraduate, postgraduate education and some special courses. So as part of my job plan, I teach undergraduates for the trust and postgraduates for the trust, again, which may be pathology trainees, it might be clinical scientists, it might be biomedical scientists, and the undergraduate clinical medical students and the clinical scientist students have a tariff associated with them. Interestingly, biomedical scientists don't, because they're not funded for training by HEE. So those are the different elements that actually make up my salary. And that all comes into a sort of aggregated budget line into the department. So behind every post is a very complicated set of financing. Sometimes it all comes in big buckets. Sometimes it's a bit clearer where all those buckets belong and when they come from. So when you're thinking about changing anything in the department, if you think about cost reduction, which again comes with quite a few management and leadership posts, you're asked to reduce your costs. The two big buckets that you would tend to do are pay and non-pay. The NHS employs 1.5 million people, and those costs are the largest element of its pay bill, as you can imagine. So if you're looking to reduce pay costs, you can have fewer staff, so you can automate things. You can also look at, they always talk about skill mix, people working to the top of their license. So you actually replace expensive staff with less expensive staff. And that's been a sort of traditional way. You can only go so far often with this. The other cost reduction approach is non-pay. So you can look at procurement. And essentially, if you go out to procurement and you say, actually, we might make a 10, 15% saving on some of the things we buy, or you can do managed services. And if you contract out the laboratory, many of you will work in laboratories where there is a managed service contract in the UK. And in the UK, managed services, you don't have to pay the VAT on your equipment because it's a managed service. So you will automatically save 20% on that. But again, those sorts of savings, you can only go so far. There is a limit to which procurement and managed service contract savings will work. And in some countries, say Southern Ireland and Europe and across some of the Arab nations, the managed service contracts may not have be as tax efficient. When you're trying to put new services, again, you need to think in the same ways. So if you're writing a business case, is it going to bring in more income? Are you going to increase your activity? Are you going to increase your quality and therefore attract a quality premium? Or is it just a quality? Is it just a quality? I'm ashamed of myself for phrasing it like that. Is it something that's essential to patient experience quality or patient safety quality? So when you're making a business case, you can make a business case based on quality, but in a financially strapped trust, often you need to make those either income benefits or savings on salary costs or savings on revenue costs or savings on capital expenditure. And sometimes you might have to ask for those, but then show the benefits, which in the benefits will either be financial savings or they'll be quality benefits or safety benefits. So this is the sort of way that you have to think about a business case. What are the savings? So when you think about it, this is what we've gone through, and I would welcome questions on that. Thank you very much for listening.
Thank you very much, Jo. Another very insightful presentation this week. Thank you very much. So I'll open it up to everybody for questions. I'm just going to start, if that's okay, Jo. As you know, I took part in the Future of Pathology report. That was a sort of collaboration between the college and Leica to sort of look about what the future of pathology would look like. And there are 4 trainees that were involved in this, and we looked at things like molecular pathology, digital pathology, and it was sort of, as I was writing, I took the molecular part on, and we're writing this, and there needs to be a huge amount of investment for a lot of what we're aiming for, and the way cancer services in particular are going to be changing in the future. What can we do? I mean, we mentioned a lot about cutting costs and things, but there needs to be an awful lot of investment in order to sort of these future things. I mean, if anybody's interested in the report, it's on the website as well. But what are your views on that, Jo? What else can we do?
So we do need investment. So we absolutely need investment. You can write a business case that will give you a payback over 15 years or whatever. And a lot of the digital pathology business cases now will justify the investment in to a trust board and to the public, the investment in digital pathology on the grounds that it is more efficient. So it saves pathology time over a period, and that it will save laboratory time because we're not always recutting slides or sending them time. It will save postage. So you can make some sort of investment in that. But when you've got a new treatment that requires a new molecular test, that's really expensive, actually the saving is maybe on alternative treatments or ineffective treatments. So you have to think about the whole pathway for it. Or sometimes you just got to take it on the chin. It's a bit like new hospitals. You know, it's pretty obvious that Whipps Cross needs rebuilding. Somebody's finally noticed. You know, we've been going, Whipps Cross we need. And so you just have to say, actually, yes, we need to have the money for that. And that's what taxation is for. It's for investment in the things that are deemed appropriate, and molecular needs a massive investment too.
Lovely. Thanks very much, Jo. I've had a few questions come through now. So one from Kirsty. How do you get good data regarding costings for a proposal?
Yeah, how do you get okay? So how do you get good data? Depends on what you get. So you can usually get quotations for what it was, and then you need to work out your revenue costs of something. So if you're putting a new analyzer in, if you're putting a new process in, so digital pathology, I'll use as an example. Actually, I won't. I'll use a new COVID analyzer. So you put a new analyzer in, then the revenue costs are the consumables, so the tests that you have to buy, the kits that you have to buy, and also the people to run it. And some of those costs will be approximate. Okay. So I'll buy a band 7 at, a whole time equivalent band 7. If you're looking at savings or the consequences, the benefits of doing that, with COVID testing, it's a new disease. So actually, there is no, it's only a quality and service improvement. It's a cost pressure rather than any benefit. If you're looking at a new drug, such as the molecular ones, it may be that it saves you bed days. That's the other way. Okay. And you can say, well, if I free up 100 bed days, then you can get more activity through the hospital, and therefore you'll get more money in. Or if you're being really, if it's something that will stop people going into hospital, if it's a completely new innovation, then you may not have to staff a ward. Now, I know we all think, we know that's never going to happen, but that's the financial arguments that you would make.
Lovely. Thanks very much, Jo. Thank you. So the top one now, we've got one from Carla. Could you explain what you mean by a managed service?
Oh, managed service contract. So instead of buying all the equipment yourself, you say to, as we've discovered, Roche or other providers, here, this is what we want to do. This is the service we provide. Go and provide us all and this is the standard to which we want everything bought. So we want analyzers that will perform at this level, and we want microtomes that cut this thin, and we want we want decent stuff. So you specify what you want, and then they provide it. Right. And they do all the replacement. They do the service contracts. They provide you the consumables, and they provide it for a price. Whereas if you buy the machines on your own, you have to pay VAT on them. Okay. So a lot of the managed service contracts are about having procurement savings or revenue savings from not paying VAT. I see. Okay. So they don't exist in some countries. Sometimes it's also convenience, because your service manager is not spending the whole time writing purchase orders for everything and business cases for new bits of kit and pleading for people for service contracts. Okay, lovely. Thank you, Jo. Yeah. So the next one, at what cost does lowering skill mix and reducing staff numbers come at a cost to patient safety and quality? Well, I mean, you must never do that if you think there's going to be an impact on patient safety and quality. You can't. A lot of the skill mix argument is around things like, so if I report a renal biopsy, I type in all the clinical details. That's a relatively expensive use of my time. And previous pay cuts in the department, pay cost cuts, have taken out admin staff. So we've now got essentially all our consultants typing away. And actually that's not a terribly effective use of time. In some laboratories, they have biomedical scientists rather than medical laboratory assistants opening packets, cutting open plastic bags. You'll see there's a getting it right first time report where there's unwanted variation just about to come out. So skill mix is something that you have to look at very clinically, very, very intelligently, and look at actually, do you really need a particular grade of person to do a particular job? Is it the whole job that needs a bit, or have you just got they took it too rich a skill mix? There are long-term consequences in that you can have a real problem with recruitment, and you can have a real problem with career development. So short-term changes can have very long-term impacts on the profession and on the career structure, particularly for biomedical scientists. So taking out a whole load of band 7s and band 6s has been a real problem.
I suppose
so
that is an impact. It's like a training numbers as well, Joe, for future pathologists. We know we've got a very big workforce issue on our hands, and I know the college has been working very hard to deal with that. But those sort of the financial figures and things, trying to argue for more training posts, those sort of things, this is sort of very pertinent with this at the moment, isn't it?
Yeah. I mean, it's interesting because in histopath trainees, you don't get the full training bursary for your salary. You do for in the first years, but subsequently you only get 50%. So the actual, there's a disincentive in histopathology if you haven't got people reporting, because there's a service charge to a trainee, and then the rest is reimbursed by HEE. So and the 50%, it's a sort of 50% contribution to service, which is paid for by the department, and a 50% training reimbursement from the department, and that tapers. So even that, if you say, oh, we'll have more trainees, that's a cost to the department, and you have to make the case for it again. It's yeah, but you can do it. It's actually not difficult stuff. You just got to get your head around it.
Okay, thanks, Joe. Thank you.
Don't be afraid of the finances. Go and spend an afternoon with the service manager and go, I'm wanting to write a business case. How do I do it?
Thanks, Joe. This is a question from Claire. Thank you, Claire. There seems to be a difficulty where investment in a test in the laboratory would save money to a different part of the trust, i.e. reduce bed stay, etc. Are there any tricks to get through this in a business case?
So the best example of this, I think you can still find it on the internet somewhere, is the liquid-based cytology business case. And they essentially invested in pathology, put money in from pathology and took it out of general practice, retrained the whole workforce, but still it had a really positive and clinically important impact on the community. By reducing the numbers of spoiled samples or inadequate samples. So that's a really good one. You can still see it's liquid-based cytology business case. I think you can see it there. And that's talking about the whole pathway. Now, sometimes we can make that case, but then wrestling the money out of another department is a different issue. And that can be, that can be done by agreement, or it can be done high up. But go for the bed days, go for that, and get clinical sign off. For a business case that crosses departments, you need to get stakeholders, you need to get friends, allies, go for the clinical leads in the other areas as well.
Okay, thanks, Joe. Similar line with Nicholas's question, how do you write an NHS business case? Is there a template or a course to enable one to produce a document that will be recognised by NHS management? Have you got any advice about that at all?
So this has been a complete bugbear of mine. Every trust has got a slightly different one. Most of them are, you can look up online. They'll have a justification, a background, a justification, quality benefits, safety benefits, cost benefits, risks, etc. There's loads of examples on the web, so have a look. But unfortunately, they're not all standard. Go to your trust. You can always ask the trust secretary.
Okay.
For a nice couple of examples.
Thank you. So another one about business case. If writing a business case, the cost may be to the lab, but saving to a clinical team.
Yeah.
It's maybe separate. Any advice about how to approach this?
So again, that's getting the clinical team to sign it off for you.
Okay.
So go to the clinical lead, go to your clinical team and say, actually, we need this. This will save you time, or this will save you bed days, and then you'll be able to put more activity through, and then they'll have to sign it off for you. Anything you do that impacts on another department should always be signed off by both departments.
Brilliant. Thanks, Jo. Is the amount of money that the CCGs receive based on clinical coding?
Yeah. So not that they receive, but that they pay out. So the clinical coding informs activity. Some primary care, again, that's coding. So you have to code procedures, or you have to code activity. So a lot of the SNOP coding that we do in pathology actually informs the clinical coding. So if we say, kidney biopsy, that the coders know that there's a tariff associated with kidney biopsy, a clinical tariff. Not that we get it, obviously. It's all right. We tell Neil, the clinical lead, that the whole time. We might get a small portion of it, but we don't actually see it. And that will inform the code. That will be informed by the coding. So trusts love coding.
Okay, thanks, Jo. I think we've got time for a couple more questions, if that's okay. Does the college advise on workforce development, i.e. appropriate mix / number of staff at appropriate grades?
No, no, we have generic. You need to have an appropriate skill mix. We've not been specific about it. There's so much variation between services, individual services. What we have, we've got some best practice guidance in the libraries, and you can find that in the web link. But certainly the UCAS will pick you up also. So there are other regulators that will pick you up if they think you haven't got enough skilled staff as a ratio.
Okay,
that has changed over years.
Thank you. It feels like we always lose out to more frontline services when it comes to training investment. How do you show the powers that be that this is a short-term view? For example, removing trainee pay premia.
Oh yeah. Oh, is that they're not going to remove the pay premium from Histo, are they?
No, I think this relates to the previous issue that we had, Jo.
Oh, terrible. Yeah, yeah. So, I spend a lot of my life advocating for decent pay premium for our hard pressed specialties and for increased training numbers. It's always a balance. It's a very difficult balance. So once we get full recruitment, we're no longer a hard to recruit specialty, and there is a risk that but then you justify it by saying, well, we're only full recruiting because we've got the pay premium. Removing the introduction of the pay premium was NHS employers shot themselves in the foot big time on that one.
It was such a bad move because training's very, very upset and very, it did the opposite of what it was supposed to do in the first place, I think.
I mean, it was not fair. Actually, to be fair, some of the contract stuff wasn't fair either. And yeah, I mean, we just continue to advocate that we try and essentially shame some trust into continuing to pay it, or not removing it, and certainly not paying it back by comparative data. And I know Matt and the trainee committee did fantastic work on that, but it's not always successful with a finance director looking at the bottom line. So
Thanks, Joe.
yeah, not good.
And then I think we'll make this last question, if that's okay, Joe, from Jasmine. Thank you. Are there any schemes similar to the Army where you may be able to train a staff member but ask they stay in the department for X number of years afterwards, so you don't invest in training and then the staff member leaves with their new skills?
Yeah. So this gets discussed at Health Education England the whole time.
Okay.
About essentially guaranteeing they'll pay for your training, but only if you stay in the health service. It hasn't gone down. That hasn't been accepted yet.
Okay.
Most people most trainees, medical trainees who leave the health service will do so temporarily, and the majority of them will come back. And that flexibility has been valued. Most clinical scientists don't leave, or they leave to work in industry.
Right.
And there is an issue about us fueling private sector and industry with trainees from the NHS training costs. Some industrial partners are now taking trainees on or supporting training in a different way, but it still is a live issue.
Okay. Well, thank you very much, Joe. I think we'll bring that session to a close. Thank you very much for your time this evening, and for an excellent presentation, and for all the excellent answers to those questions afterwards. Thank you.
Well, thank you, and we'll try and answer the others in due course. So.
Indeed, I'm sorry to everybody that we haven't been able to get through all those questions, but thank you very much to you all for joining us and for submitting the questions. Like I said, the seminars will be up on the website hopefully towards the end of this week. So if you'd like to have another look again, then please do so. And I'd love if you join us next week, same time, same place, for a session on core tools in surfing the system. Can you just send me I'm sure that's a question a lot of people have had in an email over the years. So I hope you all have a lovely evening, and I look forward to seeing you next week. Thank you.